Yes, Shiva.
Yeah, just a comment on that, on your talk. A nice study, actually.
Yeah.
But the serum calcium, which also was mentioned by Dr. Ritesh,
Yes.
I think the nadir for serum calcium post-total thyroidectomy is anywhere around 48 to 72
Correct.
hours. And the positive predictive value of serum calcium for temporary hypocalcemia within 24 hours or at 24 hours is about 4%. So that's why if serum calcium has to be used, then it has to be on day 2 onwards.
The problem is that we do it on day 1. If it is low, we correct it.
Correct.
We give calcium tablets. So there is no way to measure it on day 2.
So the problem,
I mean, it may not be
is,
correct.
the problem is most of the time what happens is the IV fluids that are given during surgery, and after that there is hemodilution happening, and when you do serum calcium, it will reflect as it's less than 8.5. It will not be in majority of the time.
Correct.
So if we are going to base the management of hypocalcemia post-total thyroidectomy based on calcium alone, so that's why parathormone is better.
Yeah.
We can start anywhere within 6 hours to the first post-operative day. But just based on hypocalcemia may not be the best thing because of various other confounding factors, and the calcium nadir taking at least 48 hours.
Correct. Very good point. Very good point. Any other questions? Yeah.
From Lakshminder's question about PTH and what is the cutoff. You see, we did the work in our center, and it was from Kerala guy Vishwanath from Parikkal. And there is a thing about PTH estimation that the sample is extremely heat labile. That means the time taken by you to take the sample and send it to the lab, if it is not properly managed, you will get a false reading of very low PTH. So what we decided that we will not go by the value, but whether it is recordable or not recordable. And if the PTH is recordable, then probably you are safe. But PTH not recordable, so the cutoff line, although mentioned 10, our cutoff line is 5, or maybe it is recordable, we are happy. The other question was about the calcium levels and the post-op. Maybe I will slightly differ. I never ask my patient on the next day, झुंझुनी आती है क्या? Because I get patient from the belt, वो सब लोगों को हमेशा झुंझुनी आती ज रहती है. So as soon as you ask झुंझुनी, हाँ बहुत आती है. Muscle में तो हाँ. So I don't ask. I wait for my rounds to be complete and then let the patient volunteer that they have got circumoral or whatever tingling. And the last thing about the
What if they don't volunteer, sir? Okay, you finish.
The timing of the calcium estimation and the symptom. You see, maybe I have got a different set, but if I have really knocked off all the parathyroids, my patients are symptomatic practically from day 1. We don't have the patient coming on day 2. I mean, the books all mention 48 hours, but maybe our calcium reserve is low in my group of patients, but they come almost, if not the night, the next day morning.
So, KK, this was the point I wanted to highlight is that many times PTH, if we do next day morning, it is 4, 6, and we are worried, hey, but patient is totally asymptomatic. Okay. And sir rightly said that many times it is thermolabile and how the sample has gone, we don't know. So detectable values of PTH is rather better.
Okay. Yes. Yes, please.
Let me give one comment and then sir can ask.
Sir, I'll come to you. There's another question from there.
So just want to know technical aspects, whatever you mentioned. Can you tell me the bipolar machine that you're using? And,
Bipolar?
Yeah, and the bipolar settings on your machines for the dissection of thyroid.
Valley Lab machine,
Yes.
and we usually use 30-30.
Okay. And so specifically yesterday when sir was also operating, you made few mention about technical adjustments in the ionic machine.
Yeah.
Can you just briefly just mention about those things just for the sake of clarity?
So there is something called as anatomy on and off, and then fluorescence on and off. Okay. So fluorescence is when only the near infrared light is shining. When anatomy is on, they have a white light also on it, so that we can see it better. So when the white light plus fluorescence is on, this fluorescence aspect may not be very clearly demarcated. So to see the glands also, along with the fluorescence, you should keep anatomy on. And when you want to see the fluorescence aspect very nicely, keep the anatomy off. So that the white light is off. and only the near infrared light is on. That's the point.
And the sensitivity and focus.
Sensitivity, when you are checking autofluorescence, it is 5, should be very sensitive. When you are using ICG, it should be 1. Because if you use sensitivity 5 with ICG, it will all be white. So when you are using ICG, keep it at the least, and when you are checking autofluorescence, you keep it at the maximum.
Focus, sir?
Focus near.
Near focus.
Near, yeah.
And ICG, how much do you inject, sir?
ICG, there's a calculation for about 50 kg, it's around 4 ml. There's a calculation for that. For 50 kg patient, it comes to around 4 ml.
But
4 ml diluted. Diluted means the whole vial has to be diluted in 10 cc of distilled water, and then 4 ml diluted, and it's a drug without much complications or hypersensitivity, can be safely used. It is being used in other departments like GI, ophthalmology and all, sir.
Sir, can I? So we have done a small study at our center for estimating the PTH level post total thyroidectomy, and
Yes.
what we have found is we did PTH estimation 3 times. One is immediate, one is around 6 hours, and then the third one is around between 18 to 24 hours. What we have found is the first sample, the second sample was not very accurate in predicting hypocalcemia development in these patients. The third sample, 18 to 20 hours, was very accurate in predicting in hypocalcemia in these patients.
Yes.
I am saying symptomatic hypocalcemia.
Yeah.
So that if you do only one sample post total thyroidectomy 18 to 24 hours, I think that should suffice. So that is one comment. The second comment is about what Manish said about using focus only. I think there are so many youngsters in the crowd. I think the proper message should be, you may use anything. You may do a bipolar or a harmonic or a ligature or ligature, whatever. The trick is you do a meticulous dissection. Even with harmonic, you may mess up the parathyroids if you're not careful in preserving the vasculature. So meticulous dissection and preventing hematoma is so very important. Preventing the vascularity of the parathyroids is the most important thing for total thyroidectomy.
One thing about harmonic is that the tip of that instrument, now they have improved. It's a little bit blunt and wide. So we don't get that sharp dissection possible with the harmonic focus. That's what I felt. But with experience, probably like Dr. Ritesh can do it.
I have used in 3,000 cases.
I know, we can do it. But
And the tip of harmonic
No, I'm not
is one of the best tip that energy devices can produce. It is far better than ligashore,
So-
sonosurge, thunderbit, anything.
You know, in my last 35 years of practice, I have never used an IUNM. I have not used a harmonic. I have not used a ligature. I have not used an ICG. But my incidence of hypocalcemia is hardly significant. So the message to the youngsters I
Yes.
want to give is, please be meticulous in your dissection.
Yeah.
Whatever method you use, you can't lose your delicacy of your dissection.
yeah, if you are there, there is no role of any adjunct, sir. Yeah, that's
So
it.
my question is whether to bury or not to bury an inadvertently removed ischemic parathyroid. You said that you detest people implanting the parathyroid in the sternocleidomastoid or in the forearm. And in your video, we saw you implanting it at the same time. So what is the take-home message?
So
Should
I'll
you
tell-
bury
I'll
or
tell
not
an-
I
bury?
apologize right in the beginning when I said that I might be expecting this happen. You see, my experience of getting a good implanted results are, you see, parathyroids are ductless glands, one. Secondly, there are a lot of septa between the islands of parathyroid cells. Now, we have to break all those septa. We have to make these cells as liberally free as possible and has as little contact, or rather maximum contact with the muscle. And that is only achieved by injecting and not by making a pocket. If you make a pocket, there is a potential space between the thing you have put in there and the muscle. And this space will be occupied by a hematoma, which eventually become fibrosis. So that's my logic in insisting that all the replace or implantation should be done by injecting, means it so much, you are able to suck it into a 18 or 20 or 16 gauge needle and get it in the syringe and then push it into muscle of your choice, whether it's malignancy, you want to put it brachyradialis or your choice. Can I ask a question myself?
Yes, sir.
Sorry, sir. आप बोलिए.
to go forward with Rajan Toprani's suggestion, it is very important for us to realize that we have two kinds of thyroidectomies, intracapsular and extracapsular. If you are wanting to preserve parathyroid, we need to go high on the thyroid and strip the capsule of the thyroid parenchyma. So carefully using any device. You can use mosquito, you can use bipolar, harmonic, whatever it may be. But stripping of this capsule along with the parathyroids is the key to all the preservation of parathyroid. And recently I have started going really back about 100, 150 years back, that if you do this stripping technique and you can identify fascia, actually there is no reason to see recurrent laryngeal nerve at all, because it is 150% below this fascia and you need not even open the recurrent laryngeal nerve, and you are 100% sure that parathyroids are preserved, except one case where Ritesha showed that it was stuck to the thyroid parenchyma. When that kind of parathyroid is existing, sticking to the thyroid parenchyma, implantation is the only method, because it is deriving blood supply from thyroid. It has no independent blood supply. And therefore, meticulously stripping the capsule of thyroid down and taking only the thyroid parenchyma must be because it is important for us to realize in this audience, there are so many people who are practicing thyroid surgery in periphery, in smaller places, where harmonic and ICG, where parathyroid studies are not possible. Are we trying to tell them that they should stop doing thyroid surgery? I don't think so, it is correct. But as Rajan has told, if you follow meticulous treatment, the incidence of hypoparathyroidism, that too permanent, should be low and they can continue to do thyroid surgery.
You see, the thing I mentioned in my talk also, पर्दे में रहने दो, पर्दा ना उठाओ. And that parda is the fascia sir was mentioning. I have a question, KK, before we close. And just one question. You have a scenario where you have visually identified the parathyroid, but your eye leak or whatever PTI will show that this parathyroid is devascularized. It doesn't glow. It is, the vascular is missing. What is your threshold to now remove this and reimplant it?
Okay, very, very important question. I didn't mention it. So, I showed the perfusion and vascularity grading. If it is both worst, like 3 and 3, ideally you should pluck that gland. If you are not seeing any vasculature and if the gland is perfusion-wise black, you have to pluck it and reimplant it. But in our hands, we theorize that, or we hypothesize that even if it is both these are black, they may improve in the body. So right till now, we have not used that technique of plucking it and reimplant. If it is attached, we thinking that we don't have we have an explanation, but we don't have a proof. So that practice we have not used of plucking and reimplantation. Only if it gets detached, we implant. So if you are not plucking and reimplanting, the utility of ICG is only documentation. All of you have to understand. It is just documenting that the gland is not perfused and the vascularity is worst. But the utility of ICG comes if you put in your department, if you have a policy of plucking and reimplanting, sir.
It is important that we start going across the specialties also. Most of the general surgeons do not use micro instruments like how ENT people are handling. And every parathyroid has a cushion of fat around that. And you should use micro instrument to handle only the fat. You should never put the micro instrument on the parathyroid, which is different color. And this blackening, I personally feel that at the beginning of the surgery, if you have noticed that, put warm saline, and by the end of the surgery, if the parathyroid has not changed and has not stopped blushing, it is important that this Vadhu is not going to be very happy. You need to pluck it.
Thank you. Thank you, everyone. Thank you so much.
Thank you, everyone. I request the moderator of this session, Dr.